Hi, my name is Alessandro Vannucchi, and I am an associate professor of hematology at the University of Florence. Here I would like to discuss with you about the main characteristics of the RESPONSE-2 study, especially focusing on the characteristics of the patients who have been enrolled in this study. And to do this, I will somewhat jump between this study and the previous one, the RESPONSE study, that has been the study that led to the approval of ruxolitinib for the treatment of patients with polycythemia vera who are refractory or intolerant to hydroxyurea. So the RESPONSE-2 study design was very similar to the RESPONSE-1, but the characteristics of the patient populations are different. In fact, in the RESPONSE-2 study, patients with polycythemia vera were allowed to enter whether they were resistant or intolerant to hydroxyurea. They were in need of phlebotomy to signify an active disease, but they were required to not have a palpable spleen, while at variance in the RESPONSE study, patients were allowed only if they had at least 5 centimeters of spleen. And also patients were allowed if they had an echo2 value, at least 2, so they were patients with active disease but no spleen. The patients were randomized to receive ruxolitinib at 10 milligrams twice a day or best available therapy, and then the primary analysis in RESPONSE-2 was performed at week 28. It was performed at week 32 in the RESPONSE study, and then patients were allowed to cross over to ruxolitinib in case they met some predefined endpoints of the study and were considered no longer benefiting from the best available therapy that was ongoing. If we compare here the proportion of patients in terms of what was the best available therapy, it was quite similar, and again also in the RESPONSE-2 study, we had a significant proportion who were still doing hydroxyurea in spite of the fact that they were resistant or intolerant to the drug. This reflects actually what is the daily practice of hematologists dealing with patients with polycythemia vera, since hydroxyurea is the most commonly used drug. And in this case, especially in patients who are poorly responders to the drug, you can increase the number of phlebotomies, but still maintain the patient on the maximum tolerated dose of the drug. So these very quickly are the baseline characteristics of the patients. Nothing new, nothing particularly unusual, but I'd like to underline the fact that most of these patients, about 60% of the patients, had received only one prior line of antineoplastic therapy, that means any kind of cytoreductive therapy. And this, of course, suggests that these patient populations enrolled in RESPONSE-2 are patients with a disease that has the main characteristics of polycythemia vera, and at variance with the RESPONSE-1 study, the lack of splenomegaly is a characteristic of most patients with polycythemia vera. So these are in terms of response. The primary response for RESPONSE-2 study was the control of hematocrit at less than 45% at week 28 in the absence of phlebotomy, and this endpoint was reached by 62% of the patients as compared to 19% of the patients in the BAT arm. There was no difference, no substantial difference between the group of patients who were hydroxyurea resistant or intolerant. And for comparison, in the RESPONSE trial at week 32, the proportion of patients who obtained the control of hematocrit was 60% as compared to 20% in the BAT arm. So very reproducible results in terms of hematocrit control. One endpoint of the trial was also the proportion of patients obtaining a complete hematological remissions at week 28, and this was obtained in 23% of the patients as compared to 5% in the BAT arm. Complete hematological remission is defined not only as control of hematocrit without phlebotomy, but also normalization of platelet count and normalization of leukocyte count. And again, by comparing the group of patients who were hydroxyurea intolerant or hydroxyurea resistant, there was no measured difference, even if the patients who were hydroxyurea resistant had a slightly lower chance of responding to ruxolitinib as compared to those who were intolerant. And again, in comparison with the RESPONSE trial at week 32, the proportion of patients who obtained the complete hematological remission was very similar, 23.6% as compared to 8.9% in the B80 arm. One additional endpoint of the study was the improvement in symptoms that was measured according to the total symptom score. And in this case, in the RESPONSE-2 study, 50% of the patients had complete resolution of the symptoms and 45.3% as an at least 50% improvement as compared to the baseline level. And this figure was compared with 22.7% in the B80 arm. In the RESPONSE trial at week 32, the proportion of patients who had at least a 50% improvement in symptoms was 49% as compared to 5%. And again, the figures of the two trials are very close. So in summary, the results of the RESPONSE-2 study confirm the efficacy of ruxolitinib in the control of hematocrit, in the induction of hematological remission, and the improvement of symptoms in what we could define as a more conventional population of patients with polycythemia vera that are indeed in need of phlebotomy, that have increased leukocyte and platelet count, but do not have significant splenomegaly. And this, therefore, suggests that as compared with patients in the RESPONSE study, there is no expected difference in the response to ruxolitinib, even in patients who might have an early disease as compared to those with increased spleen volume that can be considered as a surrogate of more advanced polycythemia vera phases. Thank you for listening to this presentation.